Thanks again, everybody, for joining. This is Carol from the STS. This is the January 4th, 2023 Adult Cardiac Surgery Database webinar, monthly webinar. I have Hank in Bristol, everybody who just knows already, but Bristol was my birthday present for me. My birthday was January 2nd, and he's Hank's new brother, both adopted from the Humane Society, and Hank's being a good boy. So on the call with me today, let me find my screen. On the call with me today from STS, we have the fabulous Leanne Jones, Melinda Offer, Addie Dolan, Banu, and Sydney. Starting in 2023, IQVIA will no longer be joining our calls. They will be providing us updates, and I'll put those in the slides. I don't have any today because we did not have our weekly call on last Friday for me to get those updates. But I will be providing those going forward. I'll go over some important dates. We have some STS updates to review, and then Melinda has STS education, and it is on risk. We'll go over that today. Thanks, everybody. Okay, so important dates for adult cardiac. January 1st was the last day to register for the virtual AQO. We will be having a AQO Hot Topics webinar on January 9th from 10 to 2 p.m. Central. Is it 10 to 2? 10, yeah, 10 to 2 or Central, or 11 to 3 Eastern time. And don't ask me to do the other time zones because I'm definitely going to screw it up. We have our user group call on January 18th. And just sorry to go back to January 9th, the AQO Hot Topics webinar is for the AQO registrants only, and more information will be coming about how to join that webinar for January 9th. Last day to claim AQO credit for continuing education credit for AQO is January 28th. We'll have a monthly webinar on February 1st, and Harvest One closes on February 10th. It's a very tight close date. And I know, folks, you're just getting back, probably everybody, just like STS staff, we're just all getting back from holidays, and it's been crazy. I'm sorry that this timeline is shortened by a week from last year. We have some reporting deadlines at STS that we need to meet, so we had to tighten up the harvest close date. So please do your best to get your cases in through December 31st with your 30-day follow-ups. Harvest 2023 dates, just nothing really has changed here. February 10th is Harvest 1, and then May 19th is Harvest 2. January training manual has been posted. The AQO Hot Topics webinar is January 9th for those who registered for AQO. And then don't forget to claim your continuing education credit by January 28th. To claim the credit, one thing I think what had happened or has happened to a few folks is you may have attended the live sessions, or you watched a couple of the recorded sessions. You claimed credit for what you had watched and then went back and watched more to claim additional credit. You have to claim your credit all at once. So everything that you want to claim credit on needs to be watched by that January 28th, and your credit needs to be claimed all at once. There's an email for Core Excel who manages the continuing education credits. So you would need to reach out to them, and I'll show you where that's at. And okay, the major change that's happened this year with IQVIA, two things is one, like I had just previously mentioned, they will no longer be on our twice monthly webinars to provide updates. I will get the updates from them and provide them, but they will not be available to join for questions and things like that. The second thing with that change, with our support plan change with IQVIA, is the questions for that were previously submitted to IQVIA. So things related to the participant reports, IQVIA dashboard, the IQVIA login, if you have problems with your password, login or password, all those things that were previously submitted to IQVIA help desk are now going to need to be submitted to the STS help desk, STS database help desk. STS will be taking over tier 1 support and then routing out the questions to where they need to go, either internally to Leanne and myself for adult general thoracic and congenital, or they'll be able to reset your passwords. And if they do need to go to IQVIA, they will be routed appropriately to IQVIA. So we're kind of reversing the flow of things. And then contact updates, contracts, and other general questions still get submitted to the STSDB@sts.org. I have my colleague Banu on the line on the webinar with us today, and Banu is going to go over this with you quickly. And I will also pull up, as she's talking with you, I will pull up the support page so you all can see where that information is housed at. Banu, did you want to say, take it from here?
Sure. Thank you, Carol. Hi, everyone. Happy New Year. As Carol mentioned, starting this year, the SDS database team will serve as the initial point of contact for database customer support. So if you have any questions regarding the platform functionality or any participant reports, please contact our new email address, which is sdsdb_helpdesk@sts.org. I will also put that in the chat box for your convenience after my update. We're in the process of setting up the help desk, and we're aiming to set it up by the end of January. So till then, we will respond back to you via email. It is important to know that, and I know that Carol just mentioned, the IQVIA support numbers or emails you've used through the last year are no longer supported. So moving forward, please use the new email address for all customer support communication. That's all I have. Thank you. And please send your questions via the Q&A box. I'll be able to answer them. And if I don't have an answer for you right now, I'll follow up with you after the webinar. Thank you.
Thanks, Banu.
Sure.
Okay, so more information on the support page. This is the sts.org homepage under registries, STS National Database. If you scroll down here for contact information, this is where you'll find the STS National Database Help Desk link. It'll open up an email with that STSDB_helpdesk@sts.org. Again, these are the questions that you would have submitted previously to IQVIA. They now will be submitted using this method. And then the STS National Database Staff Team link will go to STSDB@sts.org. And these are just the general questions regarding harvest questions, participant agreements, and updating your contacts, and also for invoicing and billing. On this page, we also have the clinical question request form and questions, the email for questions related to STS public reporting. And then I think the IQVIA page has also been updated with that correct information, and I'll pull it up here real quick. Here's the release notes for February 5th. Let me see if we can, I don't know where I would find the help information. I probably already passed over it. STS they will be correcting this or updating this to reflect the new information for the STS DB_helpdesk@sts.org, and they will be removing the phone number. More information regarding phone contact will be provided as soon as that system is set up. Okay. Thank you, Banu.
You're very welcome, Carol.
All right, and now, well, first I want to go over to, I want to go over to the questions before we get into Melinda's section, just to make sure we can, make sure we can use Banu's time wisely. And then we'll go over to the clinical monthly education, which will be on risk factors, and we'll focus on questions for that after that presentation. Vicky's asking if the Harvest One date can be changed to February 26th. And I know that it's a shortened time frame by a week from what it was last year. Unfortunately, we had to shorten it due to some reporting requirements that STS is has been obligated to adhere to. So we had to shorten the timeline to February 10th, and we cannot extend it. Apologize for the shortened time frame, and we'll see if we can do something different for next year, but for this year it is set for February 10th. Will an invite be sent for our calendars for AQO hot topics? Yes, our marketing team is working on the emails to go out, and they will include an invite for the calendars as well. Just to clarify, we did not have to re-register to receive the Hot Topics link. No, that's correct. Our marketing team is working on that communication now. For direct data entry, can more than one person have access to the data download report? No, at this time, only one person can have access to that data download report. The reason why they're doing that is my understanding is that to have, so that site has control over who has access to that report. And then that person can share it with whomever they'd like to within their facility. I want to ask about registration for Hot Topics. You do not have to register, even though you attended AQO. There may be, more information will be coming from our marketing team about the link to join. There may be registration required when you go to join the webinar, just so we can ensure that folks who registered for AQO are those who are joining that webinar. I am unable to sign onto the IQVIA and STS portal. How can I get help with this quickly? So Pam, please email the STSDB_helpdesk@sts.org. and they will be able to help resolve that for you. Do AQO participants get access to the PowerPoint slides? Yes, everything is posted on the platform, the AQO platform, where you viewed the content. The slides are there for download. Where do you find past user group meeting notes? So on the STS page, under STS National Database, the live webinars, so I went to sts.org, I clicked on registries and then STS National Database, and then scroll down just a little bit to live webinars, view webinars. Adult cardiac is the first section here. And the past recordings are here, and the past recording, the copy of the PDF slides are posted as well. When will we receive the final audit results, please? So that is in progress. I believe HMS sent those over to us just before the Christmas holiday. And Emily, I believe they sent the final set over just before the Christmas holiday. Emily is working on preparing those to send out. So hopefully within the next couple of weeks, you should be receiving them. What if you are out of office and can't access? I'm not understanding your question, Hannah. And if you could clarify that a little bit for me, please. And then Jeanne is asking, I'm getting an error for the FAQ mailbox. And thank you for bringing that up. I can probably tell you why you're getting that error. When you go to ask a question, when you go to ask a question, there's the sequence number. If you put anything in here other than letters and numbers, if you put a comma or a dash or anything like that, anything besides numbers or letters, it will send you an error. So please try to submit it using only numbers or letters within the sequence number box, and let me know if you still have an issue. If you do still have an issue, you can email me at ccrone@sts.org. I'll show you my email at the end. And then you can email me and I'll help you with that. But that's usually the issue when folks are getting an error. Oh, Hannah, okay. You are hospitalized and not available. So I think they could have contacted us, Hannah, and we would have helped them switch over the access. So you may next time have somebody reach out to us and we can work with them to try to switch that over for you. And I hope you're doing okay. All right, and Beth, I see your question. We'll have to get to that. Let's go through Melinda's education and then we'll get to your question as well. I don't know if we can answer that or not, or if it has to go through the FAQ mailbox, but we'll get to it in just a few seconds or a few minutes here. Sound good, Melinda?
Sounds great. So hi, everybody. Happy New Year. I thought we'd start the year off with risk factors. So probably for the next 2 or 3 calls, we'll be going through risk factors. And some of this may be fairly basic, good review. Some of it you might find interesting information. So we're just going to kind of go through this and work our way through the risk factors over the next couple of calls. And the ones that we're going to focus on today are height, weight, diabetes, and diabetes control. Oh, I was going to say, can I control the slides? When
I don't think so.
Okay.
I'm listening. No, I'm paying attention, Melinda. Come on.
That you can go to the next slide. So first of all, what I want to point out is that height, weight, diabetes, and diabetes control are in the risk model. Okay, so they're important. In addition, height, weight, diabetes, and diabetes control were audit fields in 2022. So it is important that we review these risk models, these risk factors. Next slide. Okay, so we're going to how we're going to review this is we're going to ask questions and then we're going to talk about the answers. So pre-op RN documents of height of 175.26 centimeters and a weight of 106.6 kilograms. There's no height or weight on the anesthesia record. The perfusion record height is 175 centimeters and the weight is 106 kilograms. What height and weight do I code? Do I choose the 175.26, which is option A, or do I choose the 175 and the 106?
All right, Melinda, as folks are answering your question there, and we have nice attendance. We have 453
I know.
participants on. So thanks everybody for joining, especially after the holidays. And I'm sure you're trying to get caught up from being off. The first one came from Catherine. It says the STS National Database staff team. The page appears blank. And then would you mind posting the email addresses for the STS DB support team? Oh, I know, Banu, it looks like your post went to hosts and panelists. So I don't know if I'll just repost it here to everyone.
I can copy paste as well.
Okay, it's in the chat box for everybody. And then the STS DB at sts.org is going to be for general database operational questions. And I'll post that there. That's going to be for things like your contracts, your billing questions, and all of that. All right, Melinda, I'm going to end your poll.
Okay, well, in the poll, and it looks like option B got 67%. This was kind of an interesting split. So let's see what the actual answer is. And the answer is B, 175 and 106. And so why is that the answer? Well, in the training manual, we have priority sources. So the first priority source is the anesthesia record. But this anesthesia record didn't have a height and weight on it. So we couldn't use that. The second priority source is the perfusion record. Okay. And then if there's no height and weight on the perfusion record, then you go to a pre-op weight that's recorded closest to OR injury. So in this situation, we had a perfusion height and weight. So that would be the answer. That would be the correct height and weight that we would take is from the perfusion record.
Okay.
All right. Question number 2. The patient height is 252 centimeters. When I try and enter this into the database, I get a legal warning. What should I do? A is leave it blank. B, enter the max allowable height for that particular patient. Oh, good. Everybody's getting this one.
That was my exact thought, Melinda.
Well, you know, I get
right at the beginning of the training manual.
I get quite a few questions like this, and I just wanted to point it out in one of these webinars.
Yeah.
But it's great that everybody's, most people are getting the answer correctly, which is option B.
Oh, I'm going to end it now.
Okay. And so the correct answer was enter the max allowable weight. Now, how do you know what that is and where that is? So it's in the data specs. So there's the link for the data specs. And then on the next slide, we'll just kind of look at the data specification. Now, the data specs manual can be found, like it's in the same section where the training manual is. You just kind of scroll down and it's down in that area. Right. So it is in the training manual when this happens. But if you're unsure about a data spec, and you're getting a warning, a legal warning, you can go to your data specification manual. And as you'll see here, when we look at height, we have a low value, we have a high value. So the low value means you can't enter less than 20 centimeters, okay? And because it's in that red area. And the high value means you can't enter more than 251 because that's in the red area. These usual ranges, on the other hand, are just, I would say, typical heights, right? You can enter the usual low and the usual high range. They're kind of in the yellow areas, but you might get a warning. They're not a legal warning, so they might just say, oh, better check this, make sure you entered that right, because it's outside of that usual range where most people have their height at. So hopefully that explains that a little bit. You guys understand that better. All right, question number 3. The medical record documents no diabetes history. The pre-op A1C is 6.6. How is diabetes coded? No or yes?
Let me know when you'd like me to stop and when you're ready to move on,
I
Melinda.
think that's good. We've got a pretty good representative, 82 to 18%, with the 82% being option B, which is the answer in this situation, because an A1C value of greater than 6.5 within 3 months prior to surgery, they had a pre-op one of 6.6, is acceptable to code yes to diabetes. So if you look at your A1C, it's collected within 3 months of surgery, and it's greater than 6.5, you can say yes to diabetes. Right. Number 4, the patient has a history of gestational diabetes. Patient is on no treatment for diabetes. The pre-op A1C is 5. How is diabetes code? Yes or no? Yes is A, B is no.
Oh,
It just amazes.
I thought this was going to be more split.
Well, it amazes me how fast these answers come in. These people got their fingers on that button for sure.
Yeah, right.
So, it's kind of about the same split as we had last time. Pretty close. I think we can probably end it now.
Okay.
So 87% of the people said that the answer was no, and the answer is no. So when you look at the training manual, it specifically says that we code no for patients with steroid-induced hyperglycemia and gestational or transient diabetes if there's no supportive documentation of diabetes, such as, a current A1C that says they have diabetes, or they're still receiving treatment for that diabetes. So this patient had no treatment, her A1C was normal, and she had a history of transient or gestational diabetes. So the answer to diabetes would be no.
Okay.
All right, question number 5. The patient has a history of pancreatic transplant for diabetes. Patient is on no treatment for diabetes. The A1C is 5.5. How is diabetes coded? Yes or no?
Oh.
This is a little more split. Wow, this one's a little more. I knew this one would be more split.
Yeah, but it sure is.
Okay, I think we can stop it. About a 60-40 split here going on. And the answer is yes. So this person would be coded as diabetes because they've had, and I'm trying to remember the exact rationale. It's in the training manual, but I think it has to do with that they actually did have significant diabetes, and diabetes has systemic effects in your body. And so a person that actually has a pancreatic transplant for condition, which means their diabetes is pretty bad, we allow this to be coded as a history of diabetes.
Yeah, I remember that same rationale, Melinda.
Okay. Question number 6. We're really diving down into diabetes, aren't we? Patient has a history of polycystic ovarian syndrome. The patient is on metformin at home. Her pre-op A1C is 4.9. How is diabetes coded? Yes or no?
They are coming in fat. The answers or responses are sure coming.
The answers come in so fast. It's like, these are always so much fun to do. I always like doing these myself. It's like,
When you got some good questions, we're gonna get to.
okay, so I've got 16, 80-20 split going on here.
Okay,
All
we're
right.
good.
I think we're good. And 80% of the people got option B, which is the correct answer. The answer is no. And the key takeaway here is that not all patients that are receiving diabetic medications are considered diabetic. Okay. And it's quite, polycystic ovarian syndrome is one of those syndromes that quite often is treated with metformin and the patient does not have diabetes. So sometimes diabetes medications are used to treat other conditions. So keep that in mind. All right. All right. Question number 7. A patient is newly diagnosed with diabetes upon presenting to the hospital and is administered insulin prior to surgery. How do I indicate, what do I indicate for diabetes control? So now we're talking about diabetes control. So they came into the hospital, they got newly diagnosed, they got put on insulin prior to surgery. So do we say that the patient is on insulin prior for diabetes control, or the patient has none for diabetes control? This one's interesting split. 70-30 going on here.
Okay, good.
Well, yep, that's good. Okay, and the answer is none. Okay, so the key here is that for this sequence for diabetes control, it's the patient's diabetic control at home. Okay, so this patient, newly diagnosed, got insulin in the hospital. We don't capture that control in the hospital. We want to capture the control that the patient is on at home when we capture the control for diabetes. All right, next question. All right, patient pre-op A1C was 8.7. Insulin is listed as one of his home medications, but the H&P reports the patient's not using the insulin. How do I code diabetes control? A for none, B for insulin.
That may be why is the A1C is 8.7.
Probably so. He's supposed to be taking that insulin.
Oh, you got a split here.
I knew this one. We're going to have a good split on this one.
Yeah, this is.
I almost gave the answer away in the last answer, but I bit my tongue. I was about ready to say it. I was like,
Anybody? Anybody else?
yeah,
shot at
okay.
it.
So that's about a 50-50. This is a real interesting split. Okay, let's see what the
Alright.
answer is.
I was hoping for one more response, so we could have had a 50-50.
Oh, 51-49. Okay, and the answer is insulin. Okay, so the intent is to capture the prescribed level of medication the patient needs to control his diabetes or her diabetes. For example, when a patient is prescribed insulin for diabetes control but is non-compliant, you're to capture insulin as the control method. So this patient needed the insulin to control the diabetes. That's what the physician had prescribed, but this patient was non-compliant, but we want to capture the prescribed treatment for this patient, despite the patient being non-compliant.
Okay.
All right, I think we have one more, or maybe two more. Okay, patient is on oral metformin and sub-Q Byetta at home for diabetes. How do I code diabetes control? Do I code oral or other subcutaneous medications?
Another good one.
I just sat around during the holidays thinking of good questions.
I figured as much. I figured that's what you were doing it while you were snowed in and frozen in.
Exactly. Yeah, definitely when I was frozen in.
Mm-hmm. Okay, ready?
All right. That looks good. So option B, which is other subcutaneous medications, scored 89%, and that is the correct answer. So again, when we're choosing diabetes control, we want to choose the most aggressive therapy, and we have an order. So insulin, of course, is the most aggressive, and then other sub-Q medications like Byetta, that's one of those other sub-Q medications, then oral, then diet, then none, and then other adjunct treatment. And of course, unknown is the last option. So remember, you can only choose one, so we choose the most aggressive therapy that the patient is on when they're on 2 or more therapies. Is that my last one? Oh, no, got another one. Okay. Patient is status post a pancreatic transplant for diabetes. Patient is on no home medications for diabetes. How do I code diabetes control? A, diet, B, none, 3, other adjunctive therapy, which is non-oral, non-insulin, non-diet. Oh, this is an interesting split too.
Mm-hmm. Oh boy.
Yeah, that maybe this was good to go over risk factors. I think
Yeah,
we all
I think it's great.
I think our brains get dusty. I know my brains gets dusty, and it's good to review these things.
That's funny because I was just thinking that, like, I haven't abstracted, a case in a few years, or cases in a few years, besides answering questions that come in. And I'm thinking, man, I would really need to have my training manual open right now, like going through these questions. I would really need to have my training manual open for abstraction. Okay, I'm gonna end the
All
poll
right,
here.
this is a very interesting split. So it's kind of all over the board, but it looks like option B got the most points. But let's see, the real answer is option C, other adjunctive treatment, non-oral, non-insulin, non-diet. So for patients who've had a pancreatic transplant, we're going to code other, since the insulin is from a new pancreas. Okay, so again, it kind of, this person had diabetes bad enough, first of all, to have pancreatic transplant. So we're definitely going to say they had a history of diabetes. And then we're also going to capture that the treatment as an other type of treatment because they had a transplant for their diabetes. Is that the last one, Carol?
I think that's it.
All right, well, it's Q&A time now. Let's see what we can how much trouble I can get myself in.
Let's start with Beth. Let's start with briefcase question. And I think that somebody else,
Karen's, okay.
is that Karen? Okay, let's start with
Karen.
Karen's questions, and Christina says she has the same question. So we'll hit
Okay.
hit two of them with one. If anesthesia and perfusion use height and weight from pre-admit visit, but the RN takes weight on day of surgery, why are we using the anesthesia and perfusion height and weight?
Well, we chose those weights because those are the weights that, as priority, because those are the weights that they plan their surgical care on. Anesthesia is dosing medications on those weights and providing care of the patient based on those weights. So that's the weights we want.
That's right, yeah. Okay. For height, for a patient with bilateral leg amputation, it would not accept the shorter stature. What do you do in that case?
Okay, now correct me if I'm wrong, Carol, but way back in my brain, I believe you entered the correct height of the patient because their organs and all are for a BSA of that height and weight.
What do you mean the correct height and weight? Do you mean
Like if you know what they were before they got their legs cut off, the height they were. So if they were 5'8" before they got their amputation,
yeah, but
then
I think I think this is something we probably need to bring back to the surgeons to ask. Because
yeah,
I think
it's there somewhere in a really
okay.
old training manual. I'm going to research
I
it.
remember
'cause-
this coming up too, and I can't remember the answer. The only thing is I don't want to get us in trouble with
No,
with our other answer that we just gave, that this is what we're dosing height and weight off, this is what we're dosing the medications off of,
yeah,
because their bodies, their BSA, their body surface area is much different now that they've had an amputation. So it's
Yeah.
probably something we need to revisit with the surgeons.
probably because I think in the old days, that's what we did.
Yeah, I agree with you, Melinda. I remember that from like 2014, 2013,
Mhm.
2014. I think I remember that, but we should revisit this and then provide an update in the training manual.
Yeah, that's a good one to bring up again.
Yeah, good question, Bill.
Um,
Oh, okay, here's a good one. I thought you could tell the auditors where you consistently use your source documents. So that's true. You should tell the auditors where your source documents are listed, but you still need to be abstracting according to what the training manual says. So we're not saying that you're saying, are you saying now we are not allowed to do that for height and weight things?
well, I think in the past, height and weight was gathered from all sorts of places. And when the auditors came in, you said, oh, this is where I always get it. And then we had multiple areas of confusion, multiple questions. And so I think it was in version 2.9, we decided that we would give a priority source to make it easier for abstractors to know where to obtain the height and weight, and also for the auditors to know where to look for the height and weight.
Yeah, I agree with that. I agree with that, Melinda. If you click the red question mark, you can see the valid and usual range in the database. And I'm going to take this one, and then Loretta's questions with the 252 centimeters is 8.4 inches. You would really input that without being able to verify it. I'm going to take both of these together, and I'm going to go back to the training manual. 1 second. So what you're seeing, I don't know which vendor software you're using that has a red X, or if it's direct data entry, but the vendors are to program in the vendors are instructed, and we'll use INR for this example, and then we'll address the height as well, the height that Loretta brings up as well. The vendor, your software vendor and direct data entry through IQVIA are instructed to use these values, the low value, the high value. This is where you're going to get a critical error, or an error that it's not an acceptable value if it's inside this red range, if it's lower than the low value or higher than the high value acceptable values. there's a usual range low and a usual range high. Like Melinda said, this is usually the usual INR on your lab. When you get a lab report back, it'll have high and low ranges. It'll say 0.9 or 1.30 or somewhere near that. And that's just the usual range where the lab values typically fall. For cardiac surgery patients, we know that their values are often outside of the normal ranges. So you may see something that is a little bit lower than 0.9 or something that's a little bit higher than 1.3, but we would never accept anything into the database that's greater than 30 or lower than 0.5. So when you see the valid and usual ranges, the usual range is this green range. That's typically what normal patients are going to fall within this green. The acceptable ranges includes the value from the lowest acceptable to the highest acceptable. It's usually very wide, oftentimes a very wide range, but it's what we have typically seen patients not to fall outside of. And if they do fall outside of it, we revert back to the lowest or highest acceptable value for risk modeling purposes. Now, when Loretta asked about the 252 centimeters or 8 feet 4 inches, when we go down to height, oh, of course. When we go down to height, and let me pull this up in the data specification document.
It's on that slide, I believe, Carol.
Oh yeah. When we go to height, we have the usual ranges 122 centimeters to 213 centimeters. That's our usual range. Our acceptable range is from 20 to 251. If you put anything over, well, you can't enter 252. So that wouldn't even be allowed. If that patient, and you wouldn't even be able to enter that into your vendor software. You couldn't go any further than that value. You'd have to stop. It wouldn't be accepted. You'd have to revert back to entering in 251, which is extremely tall. And you would get a warning saying, hey, are you sure this is accurate? So there's a flag that there's an error flag or a warning. I'm sorry. There's a warning flag that will fly if you're within the low and high values, but outside of the usual range. You'll get something that says, hey, are you sure this is right? I usually go back and check those to make sure you didn't accidentally enter in an additional digit or put the decimal spot in a different spot than what was supposed to happen. And then there's another flag that flies that says, this is absolutely not acceptable. You need to go back and change this value. We're not taking it into the database. And that's when it's that value would be below or above the acceptable ranges, which is notated by the low and high values.
Yeah, and I know that wasn't a great question, but I was trying to think of another question for height and weight. So it's like,
Yeah,
okay, there's only so many questions you can think about height and weight. And so I think this is actually, it's a good review of the data specs, and so that people understand, the max allowable limits that the field has. In all fields, pretty much every field has the same, if you're entering numbers, they've got max allowable entry values that you can enter. Okay, number 3.
Sure. Judy's question is, I think the A1C can be greater than or equal to 6.5 to get a diagnosis of diabetes.
It's true. That's true. That's true. I probably just mistyped the equal sign, or it didn't get put in, or yeah.
We'll just
we just have to put a little equal sign in there.
Yeah.
Okay, and
where'd it go? Which question was that? 3?
Number 3, yeah. Let's put it. Yeah, there we go.
Okay.
Thanks, Judy. She's always keeping me straight.
Yeah, Judy's good. Can you show the explanation for question 3 in the poll? So do you want to talk about question 3 again, Melinda?
Well, The American Diabetes Association considers people that have an A1C of equal to or greater than 6.5 to have diabetes. So with that recommendation out there, many years ago, we decided, I can't even remember what version it was, but we decided that we would take that recommendation too. So if we have a patient that comes in and they've got no history of diabetes, but you draw A1C pre-op on the patient and it is above or equal to 6.5, then we can code yes to diabetes based on the American Diabetic Association guidelines.
Okay, thank you.
Okay.
On
I
the
think-
weight, do you round up? On the weight, do you not round up?
Well, we generally don't round up on anything. The weight, if on the data specs, I think you can enter out to the hundredths, if I'm not mistaken, on the data specs. Is that true, Carol, on the data specs? Can I see that slide?
Oh yeah, sure. Hold on one second. And we found the oops. Dear Lord. Sorry.
330, number 330. Yeah, there. So we can enter to, nope, we can't. So I think that so it's not out to the hundreds. So
No,
some
so
place,
just enter, yeah, if it's 133.37, just enter 133.3.
yeah, no rounding.
Yeah, we're not rounding. Yeah, and thank you. I found it. I see it now in the training manual, Melinda. For patients who had lower extremity amputations, code the patient's original height.
I thought it was there. I thought
Yeah,
it was
it's-
there.
Thank you.
Because it has to do with the size of their organs and I don't remember all the technical stuff, but I remember having this discussion. Thank you for whoever found that. I thought it was there.
Yeah, quite a few people responded back, so I'm sure that they've had those as questions as well come up. Julia, somebody messing with my questions. Julia said, "Happy New Year, everybody." With the next congenital heart surgery database release, I'm gonna go. Okay, if a patient is diabetic and on no meds, what do you mark?
Well, you'd mark yes to diabetes because they have diabetes, and you would put none. Well, if there's no diet, I mean, if there's no documentation that the patient is on no medication or no treatment, or they don't use any diet or other adjunct treatment, then you would just say none for the control.
Okay. And then,
which one are we on now?
is there any specific time frame for question 8? Well, let me go over there. Hold on.
I don't think so.
So, is there any specific time frame, for instance, a patient who has not taken meds for months and is in the same rule for other home meds? And is this the same rule for other home meds?
This is the rule for diabetes, and this came directly from surgeon leadership. So this is not the rule for other meds, and there is no time frame at this point. I suspect if they've been off their insulin for several months, their A1C will probably be 15 to even be more detrimental to their health. So yeah, I think this is just specifically, this language is specifically for diabetes.
Thank you. If there's no height and weight in the anesthesia and perfusion records, can we use the pre-op nurse's height and weight?
Correct. What you do is, if there's none on anesthesia, because that's number 1, if there's none on perfusion, because that's number 2, then you go to the height and weight recorded closest to the time of OR entry procedure, whether that be an RN or an aide or whoever documented that wait closest to the time of OR entry.
Thank you. Did I miss why IQVIA has been taken out of the tech support loop? They're not taken out of the tech support loop. We're just gonna loop it a different way. We're going to start with STS as the initial point of contact for issues, either with operational issues or platform issues. STS then will reroute those appropriately, either internally to operations staff at STS or to IQVIA if there's a problem within the platform. STS has the ability to do password resets and answer reporting questions and simple platform questions. So STS will be taking those on, and then we'll loop in IQVIA as needed. I've always had a hard time explaining to my peers why the difference between the outcome titled major complication or operative mortality versus operative mortality. Please advise. The difference between the outcome titled major complication or operative mortality. So it's, I believe, I'm not sure, Julie, you may want to send me a screenshot of where you're looking at, but major complications or operative mortality versus just operative mortality. The former major complications or operative mortality contains if the patient had any major complication or an operative mortality. Operative mortality is strictly operative mortality.
Mm-hmm.
But send me a screenshot, or if you need additional clarification, I'm happy to provide that via email. I noticed in our EMRs, the weight in the anesthesia record will sometimes change as additional weights are entered during the hospitalization. The anesthesia record will sometimes reflect the most recent weight, not the one closest to surgery. I usually start abstracting cases the day after surgery, and if audited, the weight may no longer be what was entered.
I just recently spoke to a data manager on the phone about this, and she was upset over her audit because the weight on the anesthesia record, and I can't even remember, I think it's Epic, but I can't remember if that's really Epic or not. But the EMR, when she abstracted the case, the weight was right there for the surgery date, but then as the patient goes through, the weight changes. So it's kind of like a system issue. But what I suggested to her, just because she had an audit and she was trying to adjudicate some of those results, was to take a screenshot of, the weight on the anesthesia record at the time of surgery for the adjudication for the audit. But I know that, like I said, I can't remember which vendor, which software this is exactly, but I know that there's an issue out there like this. And I haven't had time to talk to Carol because Carol was off, and I took this call within the last 2 weeks.
Yeah, we'll have to talk about that, Melinda, because it is Epic, and I had that issue too, where Epic automatically updates the anesthesia record. And I think, Kim is saying contact Kim if you want a workaround for this. Thanks, Kim.
Oh, good. Yeah, I figured there's got to be some workaround for this because it's
there might be, and I can't remember. Thanks, Kim, for helping that. Hold on 1 second. I'm going to try to figure out how to put your information in the chat box. Okay, thank you, Kim. And we can talk about it. But Kim, maybe you want to email us the workaround too, or maybe
that would be great. Or maybe Kim wants to tell us now.
Yeah,
it would be great because if you could email that to me, because I get this, and it is an issue. It's a system issue. That we really
Wendy's saying that it was Epic for her. She had to place a ticket and they fixed it for her.
Oh, okay.
Kim's going to send us a step-by-step screenshot to
Thank
share,
you.
so we can talk about that on the next webinar. Thanks, Kim. Okay, let's see if we can get through more of these. With I've noticed in our EMRs, the wait and anesthesia record, oh, we just did that one. I had the issue as well. I had to work with my anesthesia and IT team to ensure the record is locked after the procedure. Okay, thank you, Darlene. Thank you. If the anesthesia record has the height and weight in pounds and inches and the perfusion record shows kilograms and centimeters, do we calculate from the anesthesia or use the perfusion record?
Well, I guess it depends on your vendor. And that's not a good answer, but most vendor software that I've seen, and I've seen a lot of them, you can either enter height in inches or centimeters, and it'll convert it to centimeters for you, or vice versa. So, because to have you do it manually is time consuming. So my question would be, does your vendor do that little calculation for you? Because most that I've seen. But if not, then let us know, because Carol and I'll have to talk about that.
Yeah. Here's a question, Melinda. Many patients who have bariatric surgery no longer need diabetes medication. So how is that then coded?
Well, if they have a history of diabetes, because we've got a time frame, capture any occurrence between birth and OR entry, except for that gestational diabetes. That's a special little statement in there. Okay. So if they've actually had real diabetes, not steroid induced, not gestational, then we'd say yes, that they've had that history and they're on no medications.
Okay, thank you. If diabetics are, they are diabetic, controlled by multiple oral medications, multiple insulins, and other sub-Q, do you mark sub-Q or other? Other sub-Q or other?
They are on multiple PO meds, multiple insulins. Well, insulin's the highest level. You can only code one. So if they're on insulin, then you would code insulin, because that's the most aggressive treatment.
Yeah, the most aggressive. And this is the order that we're saying. This is the most aggressive to the least aggressive.
Right.
Okay. I feel that putting insulin for a non-compliant diabetic looks like the physicians are not taking good care of the patient, and honestly reports that even with insulin, the A1C still isn't managed appropriately.
The surgeons, and I think this has to do with, A1C is not in the risk model, but diabetes control is. So I think that has a little bit to do with this, why we want to capture that insulin requirement for that patient, despite the patient being non-compliant. So
that's right.
Yeah. So by doing so, you're actually adding a little risk to that patient, where you wouldn't have been able to capture it if you had been capturing none for his treatment.
Right. Patients who are treated with insulin have a higher risk profile than those who are treated by diet alone or none. So you want to code what the patient is supposed to be on, so you get that risk for that patient. And then, but this is a good thing that came up from K. Robinson. Why not have a choice for the patient who isn't compliant with insulin? So we will not add that into the STS database, just because that would be very hard for data managers to locate. You may have it on some patients, but it may not be on every patient who is prescribed insulin, but not taking it as prescribed. However, if you want to do this at your site, you can have your vendor add in a site-specific field for you to capture that.
Right.
Anesthesia weight. If the anesthesiologist doesn't select ready for procedure, the weight will continuously update throughout the hospitalization. It's a dynamic field. Thank you, Betsy. Yeah. Thanks, everybody. Montrose does not convert. There's a website, I think, that can convert. You can use
Inches to centimeters. Yeah. If your vendor doesn't do it.
I have a physician who on his op report puts type 2 DM For any patient who has a hemoglobin A1C of 5.7 or higher, how would you code this? Because the patient is not diabetic until 6.5. I think.
Well, I would first educate my physician. And especially, you say, hey, you put this on everybody's op note. And I'm just curious why you do that, because this is what the American Association of Diabetes calls diabetes. I think that you need to have a conversation with the surgeon.
Okay.
That's a difficult one. That's a difficult one.
I didn't answer the question about cardioplasia yet because I was focusing on the questions that we were going over today.
Yeah, I can do that. I can answer that question. Is that
Okay.
where we're at now?
Yeah, and then I'll take both Melissa's questions. The first Melissa question is, with the next congenital heart surgery database release in July, is it the expectation from the STS that adult congenital surgeries will be submitted to the CHSD only? Not at this time. More information will be coming out about that. We're giving the congenital sites who are performing on adults the ability to enter in those cases with more granularity that's specific. But we are not expecting all adult sites to enter into the congenital database at this time. Will this webinar be available to view at a later date? Yes. So I'll send it over to our meetings and marketing team tomorrow, our marketing team tomorrow for posting. If you go to the sts.org under registries and STS National Database, live webinars and view webinar, it will be posted under this past ACSD webinar. You'll see this is the last user group call we had on December 7th. Actually, I think this was a monthly webinar. It'll be posted, the recording will be posted here on this link under the correct date, and then a PDF of the slides will also be available. Yeah, great. You're welcome, Melissa. Great suggestion to talk to your endocrinologist and have them speak with your surgeon.
Yeah, because the more I think about it, this is an audit field, and the auditor may not, she may not be looking at all your charts and knows that he does this every time, or she does this every time. And so I think it's something that needs to be addressed, because I would hate for it to affect the audit.
Thanks.
Because technically if there's a diagnosis, then and the physician has made a diagnosis of that, then you would code that. So I think that that's a great internal improvement process for you to work on. Anything else to add, Carol?
No, I agree with you, Melinda. And I think we can talk about, I just wanted to read Beth's, I wanted to digest Beth's question about cardioplegia. And I think we can address this, and we've addressed this in the training manual, right?
Yeah, I can answer this. Okay. So when you look at the cardioplegia, if you look at sequence 2445, if you look at that, it talks about the types under the intent. So blood, and it says if any blood is contained in the solution, so any ratio. So a 16:1, that's blood. That's coded as blood. Sometimes you see 4:1 or 8:1, whatever ratio. If there's any blood in it, we capture it as blood. If it's only crystalloid, which used to be used a lot in the old days, is rarely used today. Most people, I hardly ever see just a crystalloid prime, but it used to be quite common. So why that's, and there are still some older surgeons who may use that. And so that's why the choice is still there. So I hope that answers Beth's question.
Yeah, thank you. Very informative. Going to have to change where I'm collecting height and weight. Yeah. Thank you, Karen, for that feedback. And then I have a surgeon. Amy says she has a surgeon who always says Harvest is the Lima in situ, and she has to call him out because sometimes he doesn't use the left internal mammary. So you have to correct it on the surgeon level. And I think surgeons just get so used to dictating the way that they've always been dictating, and might have said something for 99 cases, and they get one case where it doesn't apply to, but they still say it anyway, just out of habit. So you have to correct them and catch them, educate them.
And sometimes they have templates too that they use.
Yep, that's
you know?
exactly what Tracy just said. Tracy
Yeah.
just said.
Oh, okay, yeah.
Yeah, and they forget to remove this. They don't know. They might not even know how to remove things. They forget, or they don't know how. Does the diagnosis of diabetes come from the surgeon's notes or from the H&P? Anywhere it can come
Well,
from.
it's a provider diagnosis. So if the surgeon says the patient has a pre-op diagnosis of diabetes, then we would take that, as a provider diagnosis of diabetes.
Yeah. Okay, this is going to be our last question, and then we're going to hop off since we're already 10 minutes over. I'm sorry, Julie is saying she understands that prescribed discharge medications is an all or none package. If one of the three, statin, has a contraindication due to elevated LFTs, how is this done an analysis?
I don't understand what she's asking me. Well, if it's contraindicated, it won't be fallout because it's documented as contraindicated. I'm not sure what one of the three. Is she talking about beta blocker, statin, and aspirin?
Yeah, I think you would still meet the measure.
Yeah.
I think you would still meet the measure. I'm not sure that, let me double check though before I put my foot in my mouth. Hold on
I
one
feel
second.
confident you would because it's contraindicated. So they went home on aspirin, they went home on beta blocker, and statin's contraindicated. So
Yeah, I just don't remember if the medications are excluded from, let's see here, hold on. Yeah, so they're removed from the denominator if there is if it was marked as, if the discharge aspirin or discharge ADP or discharge antiplatelet was marked as contraindicated. And I'm sure that's the discharge medications for beta blockade. It's the same.
it's the same. Yeah,
thing,
I look
yeah.
at this all the time.
Yeah. Okay. All right. Well, thanks everybody.